video all about how to treat patients with stage IIIA lung disease with resectable N2 lymph nodes. My name's Joel Dunning, and we presented and created this slide set because in our region we really wanted to get consensus about exactly what we were going to do about it, because it's controversial, and this is why. So this is a very confusing diagram that shows all the different treatments. The C stands for chemotherapy, the S for surgery, the R for radiotherapy. And actually, these are all the randomized trials between the two. So if you see either end of a stick, that biggest, thickest one in the middle, bottom left is surgery compared to top right, chemotherapy and surgery. And then top left, there's a little tiny stick comparing chemoradiotherapy and surgery versus chemoradiotherapy alone. That's the INTERGROUP trial, a huge randomized study. So if you actually have a look at all those different treatments, there's zillions of different ways of doing it, because sometimes you have the surgery first and then the radiotherapy, bottom right, or chemoradiotherapy. And then how do you compare different treatment arms that aren't even got studies between the two? So it is confusing. But we've got to come to consensus. We've got to decide what's the best treatment. And some of them are trimodality, so surgery, chemotherapy, and radiotherapy. Some are bimodality, maybe just chemoradiotherapy, etc. So it is difficult, but it's important. So if we look at this was just published last year, 2019. It's the 2017 figures of all surgery in the whole of the UK. 13%, 1 in 7 of all patients have stage IIIA disease. And then what's the definition? This can be confusing. So the IASLC have even tried to subdivide stage N2. They tried to say N2A is single station, N2A1 is single station, there aren't any N1 nodes, single station. N2A2 is single station with multiple N nodes involved, and stage N2B is multiple N2 stations. So we haven't found this that useful because it's all about resectability or not. So what else is out there? So the Robinson's classification says, well, stage IIIA-1, you just found it by luck in tiny microscopic samples. Stage IIIA-2, you found it from frozen sections in theatre. 3, you knew about it beforehand, but it's resectable, and 4, fixed bulky nodes. But what are these bulky nodes? Well, there's lots of different definitions even for what are bulky nodes. As a group, we have decided that ESTS have come out with the best answer here. So 2014, they came out with a really good determination of this. So what is bulky? They say more than 25 millimeters on short axis, not long axis. They have to be single lymph nodes. There can't be a whole huge mass of multiple lymph nodes, and they can't obviously invade an airway. So if you're less than 25 millimeters, single node, then that's non-bulky, operable disease potentially. As you can see on the left there are other sort of definitions on that exact size. But let's just take a look at some of these examples. This is what we see in our daily practice. The top 2 slides is somebody that was just found by luck. PET negative, CT negative, everything negative, and then post-operatively that little tiny N2 station that red arrow points at, top right, that was positive. But that's you probably can't do anything about. You are obviously going to find some only intraoperatively. So that's not what we're talking about. The ones we're really talking about is the next one down, the middle 2 images, where you've got a biggish, bulky-ish primary, but you've got an obviously positive N2 node. The MDT knows it, everybody knows it, but is it operable, is it not? That looks like we could probably take that one out. And probably the patients we're not talking about is image C there, massive, huge, confluent nodes everywhere, the tumour going into nodes, spreading all around and compressing the airways, the right lower lobe bronchus there. So it's that B images that we're really talking about today. Now we do actually have an easy test for resectability, and it's a VAMLA, so complete mediastinal lymphadenectomy. We do it quite a lot in James Cook. If you're not sure if an N2 node's resectable, then in the mediastinoscopy, don't just sample it, take it out completely. We can do that completely. So if we've got somebody that's a bit marginal, we're not sure, 2.5 or not, is it bulky, is it not, let's just take it all out, because if you can take it all out macroscopically by a mediastinoscopy, then you've proven it. So we do have a good definition for operable or bulky lymph nodes, and that is our definition. So that's what we're going to use. Now, the thing that's caused the most disagreement really is the March 2019 NICE guidelines. Uh, they were chaired by a consultant, a professor, a physician from Belfast. There was a clinical oncologist from Cambridge, a medical oncologist from Belfast, and Doug West, our own surgeon from Bristol, who we know very well. They did a whole literature review, 167 pages, specifically on this category that I've just described. They did their own network meta-analysis, and they came to really maybe slightly different conclusions to what we've been doing in the UK, really. So what they said was anyone in this category should have chemoradiotherapy, then surgery. And that we should be telling patients it's chemoradiotherapy, then surgery improves progression-free survival, and it might improve overall survival. They give some advice to say, do the chemotherapy, restage, and then do the operation 3 to 5 weeks after surgery, and multidisciplinary teams should be involved. So it was quite strongly worded, and it didn't really give a lot of leeway for other treatment paths. So we wanted to look at exactly what the evidence is behind this. They're really quite strong worded about it. They say that chemoradiotherapy and then surgery has an 89% probability of making somebody live longer, and it's actually better than chemotherapy and then surgery. And it was quite strongly worded. So what papers did they look at? Well, here are the 10 papers that they looked at and did their network meta-analysis, which we're going to go through. But they were pretty strong worded on it. They said a 4-month means survival advantage if you do this rather than anything else. They also did a cost effectiveness analysis and said it was cost effective, and they justified their analysis in great detail, putting numbers on it. The British Thoracic Society issued a statement in 2017. They weren't quite as strongly worded as NICE, but they did say that the INTERGROUP trial, which we'll go through, is the only trial in support of something. The EORTC's negative trial and all other studies individually have been negative trials. But they were a lot more gentle. Eric Lim came out with a meta-analysis that a lot of people know about, and he came out quite strongly for chemoradiotherapy and surgery being better than chemotherapy and surgery, even though obviously the p-value just didn't quite hit significance. If I just show you here the forest plot, the top 4 studies that he put together were the chemoradiotherapy and the chemotherapy and surgery, and those bottom 2 are the chemoradiotherapy and surgery. So his strong recommendation was actually based on only 2 studies. And we'll look at those. First of all, let's look at this study. It's called EORTC. It was a huge study across the whole of Europe, and it was chemotherapy and then surgery. The graph there shows absolutely no difference, not a bean, no difference at all, not even a hint of a difference. Now, this was a huge study. It was multi-center. It was quite old, starting in 1994. It didn't need a PET, and it didn't go great. 40% of people had R1, and there was a lot of people with bulky N2, and so it's a shame. It was negative, but this is a negative study saying chemotherapy then surgery is the right approach. This is the big study. This is the #1 study that everybody gets their clinical significance out of. This is where NICE have come to. This is where Eric Lim's meta-analysis is based on, the intergroup study. Firstly, it's pretty old, 1994 to 2001, didn't require PETs. Secondly, it's concurrent chemoradiotherapy. Our clinical oncologists have said this is really quite an old fractionation dosage, which isn't in current employment at the moment. That's beyond my knowledge, but that's what they've said. So they did concurrent chemoradiotherapy, then CT restaging. If still negative, then they would do surgery, and then 3 to 5 weeks afterwards, and then they would do 2 more cycles of chemotherapy. So a lot of treatment. But they did get a significant difference. So the overall survival just didn't quite hit significance, although there was a difference, and then progression-free was significantly different. But the interesting things about this study were that the pneumonectomies did horribly. 26% died. And so a lot of people do subdivide this study and say, well, if you take the pneumonectomies out, then actually there's a massive progression-free survival difference. 18% in those having radiotherapy alone versus 36% in people having trimodality treatment. Now, it's probably not entirely fair to do that, because obviously some in the conservative group might have needed a pneumonectomy to get their tumour out and therefore be more advanced. But maybe if you even put up the chemoradiotherapy group to 25%, then there's still going up to 36% is a big difference. They were well-selected patients, mostly single-station N2. Didn't recruit all the patients it should have, but this is, the biggest and best study in the whole field, which is why I guess NICE have come out in favour of their protocol. So Eric Lim meta-analysed 2 studies, so it was the INTERGROUP and this was the other study. It's a bit strange because it's never been published as a paper. It was published as a negative abstract, and it was closed early because chemoradiotherapy was becoming the standard of care. So that was slightly strange, really. And because it did chemotherapy, then surgery, then radiotherapy afterwards. So of note, Eric has put a chemoradiotherapy, then surgery trial together with a chemotherapy, surgery, then radiotherapy later study. And actually, it came out non-significant, although if you did adenos only, it was significant, but it was getting towards significance, which is why it probably helped in the meta-analysis. Now, there's one other huge study we need to talk about called ASTRO from 2015. This was a concurrent chemoradiotherapy and then surgery, or just chemoradiotherapy alone, and it's negative. Again, there was a big problem with this study. There was 30% of patients didn't actually have N2 disease, and a lot of patients had pneumonectomies, and 171 patients had stage 3B. So it probably suffered because it was under recruiting and it opened the recruitment too much to too wide a group, and that's probably, well, maybe why there was no survival difference. Of course, the other option is that there isn't a survival difference at all. But that is the other studies. That's all the studies. That's all the studies of chemoradiotherapy or chemotherapy with surgery versus without. Apart from lots and lots of little tinchy tiny ones. So there's chemotherapy and surgery or radiotherapy, negative study, tiny. These were the other studies in Eric Lim's meta-analysis and in the NICE guidelines, but terrible study, 31 patients and ancient. Another terrible study, Johnson et al., 61 patients and ancient, and it was another chemotherapy and surgery. Another terrible study, even though it's at the Christie's, 48 patients. All of these didn't accrue. So there's a lot of ancient, tiny studies in this area that a lot of them actually stopped because the big studies were coming along. There's one other recent meta-analysis. It's brand new, and it's where this graph, this big table came from, this weird graph, this spider-type plot, and they actually put them all together, and they tried to say which out of all these different things in a new type of meta-analysis, which one comes out top. And actually, strangely, they came out, or differently to NICE, they said neoadjuvant chemotherapy, then surgery, and then radiotherapy or chemo was the best of all of them. So it's pretty strange because the biggest study that was chemotherapy, surgery, and then radiotherapy was 30 patients. And then the other study that they said was best, or the best treatment plan, which is chemosurgery and more chemo, only had 13 patients. So nobody quite knows what to make of this meta-analysis, but that's what it found. And it put a few extra papers in, but a lot of them were papers that you did the surgery, it was unsuspected N2 disease, then what do you then randomize them to? So do you add radiotherapy or do you add chemoradiotherapy? And that's a different group to the ones we're thinking about where we knew about it beforehand. So I'm not sure it's valid to have added all these in, really. So we're getting a bit stuck. We're thinking, yes, there are some studies showing that if you put them all together, that's a good thing. But then, is chemoradiotherapy or is chemotherapy alone, then surgery, and then some chemotherapy afterwards if you don't get it all out? What is that the best treatment? So there has been a study looking specifically at that from Switzerland, and it didn't quite come out positive. It nearly did. And then if you actually find Katakami and Girard's very much smaller studies that are also on this, that are slightly older, and put them together in a meta-analysis, this does come out significantly in favour of chemoradiotherapy, then surgery being better than chemo, then surgery. What do radiotherapy guidelines say? Well, radiotherapy say, of course, if after the operation you've got N2, it might be good, especially if there's an R1, to do radiotherapy. And then it says you can consider TRIMODALITY treatment, and it's the IASLC that supports that. The thing that's muddied the waters a little bit is post-operative radiotherapy, because if you do just chemotherapy and then surgery and you get an R0 for your nodes, the meta-analyses and the studies actually show you might do harm with radiotherapy. So this scares the radiotherapy people off quite a lot, because they're saying, well, why do chemoradiotherapy at the start? Why not wait to see if you've got an R0? And if you haven't got an R0, then maybe you can withhold radiotherapy because it's dangerous. So the meta-analysis is quite old, but it did say that actually survival is worse if you do radiotherapy on people that have got an R0 for their N2. Now, a huge study was set up in the UK to look at these patients. Some people with proven N2 after an operation, should you give radiotherapy or not? Now, this is different to the group we're talking about, because remember, I'm talking about people that we knew pre-operatively that they've got N2. But this study was set up once you knew they had post-op N2. This study's under-recruited. It's shut last year. It wanted 700. It's only got 400. So most people think it's probably going to show no difference between the groups of radiotherapy versus non. Most people think it won't show a detriment of the radiotherapy, but it's probably not likely to show it's of benefit, which is a shame. So we are left again stuck. We're stuck with that question. Do we do chemoradiotherapy first, then surgery, or do we do chemo, then surgery, and then if it's an R0, we can maybe miss out the radiotherapy and then just do radiotherapy in people where we didn't get a good margin in the nodes. Obviously, the big study on the block is the Pacific trial. Now, it is different. So this is from America. It's people with inoperable N2. So this is not our group. Americans are very aggressive with their nodal dissection. So an inoperable N2 in America is really going to be inoperable. It's going to be that bulky confluent disease eroding into nodes. They are aggressive. They do chemoradiotherapy before surgery. So I don't think this is a directly relevant study, but it does show that actually maybe we'll be able to add immunotherapy to further benefit our surgical patients. Obviously, others say it could be the end of surgery because you just do chemoradiotherapy and then immunotherapy, but actually it's just as likely that you might do quad modality treatment. So there are all these studies out there recruiting right now. 3 of them are in resectable stage IIIA disease, and some have surgery in the mix. And really the answer is we don't have an answer from these, so we've got to come up with something ourselves. So one other thing we did locally was we got out our last 11 patients that did the pathway, because anecdote and fact are 2 very different things. So we looked through specifically, and I think it does tell us a bit about the pathway and our successes, and I think it was quite a positive exercise. So I'll just flip through them very quickly, because obviously if you don't know the patients it's slightly less useful. But our first patient, this is CH, left lower lobe, T3O0, had a mediastinoscopy because we do a lot of mediastinoscopy, surprise N2 on the med, so we sent for chemotherapy because our current pathway is chemo, then surgery, and then think about radiotherapy. But we always restage and do an EBUS post the chemotherapy. That was negative. Had a thoracotomy, it was N1, and referred for radiotherapy. Unfortunately, a year later, they have got metastatic recurrence and died from that. Second patient, right upper lobe. There were some other nodules around, thought to be N0, so we did a med, it was surprise N2 positive, had the chemo. Actually, this person then had an EBUS, it was still R4 positive. So they kind of broke our protocol a bit because there was a massively strong preference on the patient to operate. So they did have an operation, it didn't achieve an R0, and then they had radiotherapy, and then interestingly, a year later, there definitely is a scan from May 19 with no recurrence. This patient has died, and we've looked through the notes, and it's not from our hospital. So we think this is not recurrence related, although we haven't found the exact cause of death, but there is a negative CT. So this was persistent positive. They got radiotherapy. and they didn't recur in 1 year. Right lower lobe, known to be N2, neoadjuvant chemo, then amide, fully cleared out and was negative. Actually, there was complete pathological response from the chemo, T0, N0. Decided not to have the radiotherapy, and they're clear a year later. Middle lobe tumour, T3, surprise, station 7 positive on our MEAD, repeated everything. That was clear, had the resection, N0. Actually were then recommended not to have radiotherapy and alive and well 2 years later. Mr. CF, middle lobe tumour, wondered whether it was N2 positive or not, and then EBUS proved it. The EBUS proved it. Then they had chemotherapy. Then they had a MEAD, which was negative. Then they had lobectomy, complete pathological response. They did go for a discussion about radiotherapy, but obviously with the amazing response, that was felt not to be indicated. And then 8 months and 9 months later, still fine. Right middle lobe. T2A-N1, surprise N2 on mediastinoscopy, had the chemo, restaged and fine, had a lobectomy, decided not for radiotherapy, but has recurred. So they didn't get the radiotherapy. Maybe that was the problem, although it was multiple lung nodule recurrence, so I guess systemic recurrence. Bronchus intermedius, known N2, but the EBUS was negative, so we did a MEAD and that then showed it was 7. We actually removed the station 7 completely, then chemotherapy, EBUS then negative, had a middle and lower lobectomy, T2A-N1, had the radiotherapy and clear patient. Right upper lobe, EBUS negative, MEAD positive, chemo, restage, then a robotic right upper lobectomy, complete pathological response, didn't have radiotherapy because of the good response and currently still well. Right lower lobe, big tumour, T2A-N1, actually had loads of disastrous misses, missed for 2 years on breast scanning, then wanted to have a holiday, and then it was N2. We thought it was N1, but it ended up N2. She then had chemo. She then went for surgery, and actually she was an interoperative death. We made a big mistake here. She had surgery 2 weeks after chemo, which she should never have had. Should have been 3 to 5 weeks, so she's still suffering, went neutropenic and ARDS. That was a mistake. Interesting patient, had chemorads to a right upper lobe in 2006, fully cured, and now had a right lower lobe cancer. And actually right upper lobe looked, not too bad. MEAD positive, 2 nodes positive. Chemoradiotherapy, didn't get an EBUS, then had a right lower and middle lobectomy, T1A and a different N2, so station 9 that you can't get to by MEAD or any other way. Difficult to recover, never quite got the radiotherapy, but a year later she's still clear on CT, so that's really good. And last one, left lower lobe, MEAD positive, we'd removed the node completely, then chemotherapy, EBUS negative, left lower lobectomy, big tumour, given an R1, so definitely had radiotherapy, and it was big, T4, had an R1, and she has had pathological recurrence in her femur now. So in summary, our patients, if you go down a chemotherapy, then surgery, then think about radiotherapy, most of them, in our experience, have not got their radiotherapy. So you don't actually end up doing trimodality treatment. You end up quite often doing bimodality treatment. So, the nice guidelines, one advantage of chemoradiotherapy is you will get your trimodality treatment. Obviously, the studies are equivocal a little bit. But one thing I think we've shown is that if you do chemo then surgery, a lot of people won't get your radiotherapy. And at the end of the day, that's why we do the chemo first. If you do surgery, then only 50% of people get their chemotherapy, which I think is really bad in N2. That's why we definitely think you should have neoadjuvant chemo rather than upfront surgery. So 8 are still alive, which is really good. 3, interestingly, had T0s, complete pathological response. I mean, they may have had some individual cells that had cancer because they don't look at every cell in the path lab, but that's interesting. 3 recurrences, which out of 11 isn't bad. and we had one death in each category: a non-recurrence, a recurrence, and a death from intraoperative. So in summary, what are we now going to do in our region? What we have decided is that the evidence isn't strong enough for chemoradiotherapy, but we're not used to giving it, and we're happy with the current protocol. So we're going to do chemotherapy. Then we're going to restage. So if we had an EBUS proving the station was positive, then you get a MEAD. If it was MEAD positive, then you get an EBUS. And if that's negative, then you'll go and have your surgery. And then looking at the pathological response, we will always get them to chat to an oncologist about radiotherapy. And it's up to the radiotherapy doctor whether they get it or not. Obviously an R1 will definitely, but it's not compulsory. And that's it. We're going to treat station 5-6 in left upper lobes completely differently, because we don't really believe that's a proper N2. So if you're a left upper lobe and you've got station 5-6, we're just going to do upfront surgery. And that's our pathway. But it's controversial. What do you think? Please put a comment below this video. I'd love to hear what you think. And in particular,